Hi, good evening, everyone. Welcome back to another session of webinar. And I think this is the first time we're having a professor from University Kebangsaan Malaysia, where I graduated from in 1992. Do you know that I'm a UKM grad? Did I not
No,
tell
that's
you?
surprising. Surprise, surprise, surprise.
Oh, you never knew. I thought I
No.
did tell you. I'm a UKM grad.
Okay, so I was kowtow to you, like senior, right?
You also a UKM grad?
Yes, yes.
Oh, but when I studied in UKM, it was still in GHKL. Okay, so you were UKM grad and you became a professor in UKM.
Yes, that's right.
Wow, that's amazing. So anyway, tell us more about yourself because I myself don't know much about you. Now that I know
Okay.
that you're UKM grad, other than
Ah,
yeah.
all right. Anyway, basically, my name is Kamalnathan Palaniandi. Professionally, I'm known as Palani. I work as a lecturer in UKM. And being a neurosurgeon, I know usually people associate neurosurgery with just purely brain or tofu surgery.
Mhm.
But I tend to concentrate more on spine work as well as pain management. And at the moment, I see the bulk of my work being more of pain management, and especially I see those chronic headaches, which have been labeled as, they've got a lot of labels for headaches, and what happens is when they come, and you revise the diagnosis and all those things, and then you realize it's actually coming from the neck.
I see. Okay,
Yep.
don't give too much. We'll start with your lecture first. We know too much already. Okay, so we start.
All right. Okay. Can I share my screen?
Yeah, please.
All right.
Oh, you never knew I'm a UKM grad.
No. Okay. So I'll be talking on strategies for neck pain. Okay. It's going to be a very basic lecture, nothing fancy, nothing about techniques, nothing technical, just for better understanding. Right? So initially I started off as strategies for neck pain, but okay. But since Betty mentioned about cervical spondylosis as well, so I will just try to go through or explain briefly what I understand as cervical spondylosis. So
Okay.
cervical spondylosis is basically the tire you see, the worn out tire you see at the back. So that is basically what happens. But the only thing now here is cervical spondylosis. So it's basically wear and tear of the cervical spine. And it can be a result of wear and tear to the disc, right? That's where we talk about the famous prolapse disc, right? Joint, as well as reactive calcifications. So now, reactive calcifications are also because of wear and tear, because there's instability. Therefore, inherently, the body tries to heal itself. You get calcification because this calcification based on what happens is the body sort of induces some amount of stability with this reactive calcification. Okay, so now back to what I initially thought of speaking of.
Mhm.
So neck pain is actually the fourth most common complaint leading to disability. The mean point prevalence is 7.6%, meaning that as we speak now, 7.6% of the population would be experiencing some form of neck pain. And the annual prevalence is at 37%. So almost 4 in every 10 would be having some form of a neck pain annually. And the prevalence of chronic neck pain is about 14%. Lifetime prevalence, almost half of us would actually experience some form of neck pain throughout our lives. So the rationale here is whether whether me as a surgeon, I would agree or I would prefer not to agree because, I lose a lot of income here. Is 75 to 90% of patients with radiculopathy actually improve without surgery. All right. And only by this paper by Lees and Turner, right? They said that only 25% of patients with radiculopathy have persistent symptoms and none actually progress to myelopathy. So pure radiculopathy,
Oh,
only 25%. Sorry?
they have persistent symptoms, but they will never progress.
They do not progress to myelopathy.
But even persistent symptoms can be very disturbing, right?
Yes, definitely.
Okay.
So, um, however, with myelopathy, surgery is known to improve outcome. And as a surgeon, I will say that it will improve outcome. Uh, right? And the improvement in outcome is almost immediate. So someone with myelopathy comes to my surgery, I would definitely offer surgery because of the rapid improvement in the condition. And again, surgery is clearly indicated for those with myelopathy, neuropathy, progressive disease, and failure of non-surgical management. This failure of non-surgical management, I do have a case to illustrate later. So what would the causes be? So they could be neuropathic and non-neuropathic. So non-neuropathic would be mechanical and neuropathic, right? So mechanical would mean instability. So that's where we go back into cervical spondylosis. There's micro movements or even macro movements, which, excuse me, results in pain of the joints. And neuropathic pain, of course, there's always nerve root compression. That is what everybody understands easily. But there's another component of neuropathic pain which is associated with this mechanical pain, particularly so when the facets are involved, because now this facet pain becomes chronic and there's aberrancy of the sinovertebral joints, the sinovertebral nerves, which results in this neuropathic pain. And there are certain red flags or yellow flags which we need to be aware of. We'll go. So now facet pain is actually one of my favorite because it's easy to diagnose and management is also fairly straightforward. And also, you can just dispense some simple advice if, let's say, you are a GP or so. You do not need to do anything very fancy. And patients do experience improvement. And of course, in terms of the numbers, almost half of neck pain patients actually have this facet arthropathies. So they are usually progressive in nature, right? And however, whiplash injury is an exception because that's an acute event which results in disruption of the facet joints. Now, there is this facet pain, right? One of the hallmarks is paraspinal tenderness, right? And this tenderness is actually due to spasm. So in simple terms, there is some form of a micro instability, and these paraspinal muscles, they go into spasm to help improve the stability in its own sense. So it's kind of
Okay.
like trying to brace itself.
But doesn't the
And
spasm itself is very painful?
yep, exactly.
Because I had it before.
So that's why there's paraspinal tenderness,
Oh,
right?
it's, oh, yes.
Um, But you know, when I see patients, they tell me that most of them, they do not really complain of neck pain. They tend to complain of pain somewhere around the trapezius area, the distribution of the trapezius muscle.
Okay.
Yep. And then eventually, when you go and palpate the joints, then they jump in pain. And then eventually, you know, when you start treating them a step ladder pattern, or some of them might say, "Doctor, look, it's so bad. Just do something. I want it to go away." Then you go and give a diagnostic block. And then they tell you that, "Doctor, now the pain is gone, or the pain has improved very much."
Yes, I can imagine.
So
Uh,
now, there is no direct correlation between radiological findings and relief at intervention.
There's no, sorry, no,
There is no direct correlation between
uh,
radiological findings and relief at intervention.
I see. So when you intervene, the radiological findings can still remain the same.
Yes, the radiological findings will remain the same when you intervene in terms of, because here we are talking about stable spines whereby there is no need for surgery. So
Yeah.
the intervention here would be more
Pain relief.
yeah, interventional pain relief, or or you know, medical pain relief, which would be medication, obviously. And you would not expect to see any changes. And in fact, if it's purely facet joint pain
Uh-huh.
in the neck, even if you do an MRI, you can have a pristine MRI.
I see. So this relief at intervention, you're going to tell us how you're going to relieve the pain, right?
Yep,
Okay, we
I,
go.
I do have some images on that.
Okay.
Okay, so to me, this is actually one of the most important slides, because remember facet pain, right? So number one is facet joint tenderness. That is a no-brainer. You actually palpate on the facet, there's pain, right? But here, remember I was telling you where they will complain of pain along the distribution of trapezius?
Okay.
So
Yes.
this diagram here is more or less following the trapezius, actually, if you see, except you do not have the, you know, the sharp angulations of the muscle bellies and whatnot. Because the trapezius actually starts its insertion somewhere near the occiput and goes all
Do you
the
have a
way down to the
pointer to
toe.
show us? I
Hold
think
on.
you just, there, yeah, you do, you
Yep,
do.
you can see it, yeah?
Right.
Okay, sorry.
Sure. Yeah.
Yep, so usually the trapezius it goes around here, right?
Huh?
So now all these markings in color, they are somewhat along that lines. So now this, if the patient complains to me, the most common would be C4, C5, or C5, C6. So if the patient complains, okay, look, I've got this pain and tenderness over my, or I have tightness over the nape of my neck, which goes to my shoulders, to the top of my shoulders, then I would, you know, in my mind, it'll automatically click that, okay, it could be C4, C5. Or being the lazy person I am, I'll just automatically go to Google, pull up this picture on Google, and ask the patient, okay, now you tell me, you know, the pain, the distribution of the pain, the stiffness, which color do you identify it with?
Okay. So the red is the most severe?
The red is the most common.
Oh, I see.
You see, in terms of this herniation, C5, C6 is supposed to be the most common, followed by C4, C5. But in terms of facet tenderness, in my experience, what I've found is C4, C5 is the most common.
And this color tone and the pain, is it because of dermatome? No.
No, it's not exactly dermatome.
Is it, it is just,
It doesn't follow a dermatome. It
it's just
is,
spasm of that area of muscle?
yes, it's more related to the spasm of the muscle area. So if I were to talk on lumbar facet syndrome, now there's going to be another similar kind of a diagram, but of course it's down in the legs.
Okay.
And this does not follow the usual dermatomal or radicular pattern. Okay, so now this is briefly on how I would do it, or what I routinely do. So if you actually see my thumb there, right, it's not bracing
Okay.
on the patient, but it's actually I'm trying to press on the facet joint
Uh-huh.
to elicit the pain. And usually on if I hit the sweet spot, the patient wouldn't be very sweet to me. Right? Patient will be jumping in pain. Doctor, look, what are you doing? In fact, this yesterday I saw a patient. I did the same thing in the clinic, and then did the intervention this morning. In being in government practice, you can't do it immediately. You do not have the luxury of seeing in the clinic and then after half an hour doing it, taking the patient to OR. So when I saw the patient in the operating theater for the injection, then the patient told me, "Doctor, what did you do? The pain is still there from yesterday." But fortunately, about half an hour after the intervention, she said, "Okay, doctor, now the spasm and all has reduced. Just
It's
now there's
not
some
you by
pain over
touching
where you
her,
poked."
you by pressing the area will diminish the pain.
Yes, you can actually. But that is not over there. That's over the trigger points. That one I'll come to it later.
Oh, I see. Okay.
And if you're doing a GP practice, if you can, if you just give the trigger point injection correctly, trust me, they'll be very happy.
Okay. Let's look into it.
Yep. So it basically you just hit the sweet spot. So in this particular patient, these are the sweet spots. And again, I'm using the image intensifier to make sure that to have a more precise diagnosis, because and whatever anatomical landmark you're using and all is very approximate. But now once I've found my tender points, then I confirm it radiologically. That is just more for documentation purpose. Patient doesn't care where you poke as long as the pain improves and there's no complications, right? So this is done under image intensification. I know some of the experts who are very comfortable with ultrasound, they do it at ultrasound, but I prefer to use the image intensifier uh, because it gives me a very fixed anatomical landmark and precision, and as well as for documentation purpose, it's very reproducible as opposed to ultrasound is very operator dependent. And my ultrasonographic skills are probably not that good.
Non-existent.
Yeah, exactly. Actually, I wanted to use that word. Yeah, same thing as me doing
Sorry.
angiography.
So sorry.
It's because again, you're trying to hit on the bone, and ultrasonography is not that good
Hmm.
for bone,
Yes.
right? And of course, for documentation, it's much more easier. And some people, they do not like to give any form of injection into the neck area because there have been reported issues of very, very adverse events. So anyway, to simplify things, I just square it, I hit it smack at the middle of, I try to hit it, right? I will not hit it all the time, right? At smack at the middle of the lateral mass, that's where the medial branch uh, is expected to run through. And if let's say I'm trying to block here, it's the C3, C4 joint. So I will need to give a block above and below because it's got dual innervation most of the time. And then, of course, confirmation using contrast agent. So this is something which, to me, the radiograph or the image intensifier in the OR gives me an advantage. because I can make sure that, I do not inject it into the surrounding vessels. And higher up in the neck, there's a much more larger venous plexus there. And inadvertent injection of material into the venous plexus, especially if you're using particulate steroids. So those of you who are thinking of using this, and you're good at ultrasound, you say you want to do, I mean, if you're good, go ahead, but please avoid particulate steroids. That's your shin cord, right? Francinolone. I would just use dexamethasone. Yeah, maybe it doesn't work that long, but at least the risks are much less.
What are the risks with using the other steroids?
When you use a particulate steroid, right, and then it goes into the venous plexus, then it floats itself, and then becomes an embolic material.
I see. Okay.
And there have been cases reported where there have been infarcts as a result of that.
Okay.
Okay, we shall move on to discogenic pain. So now, unlike the lumbar discogenic pain, there's a lot of definition to it. People have done a lot of studies, and there's a lot of defined or well-proven ways to treat them. But cervical discogenic pain is not clearly defined, right? So now when I say discogenic pain, it's nothing to do with the disc herniation. It is the annulus itself is feeling some form of an abnormal pain. It's an aberration. Right? So, and it's usually neck pain associated with stiffness again, but here is more of a generalized stiffness because, again, whatever movement, especially a sudden jolt, I tend to ask patients, when you are driving the motorcycle or if you are driving the car and you happen to hit a pothole, and you sort of compress, there's that sudden compression and release mechanism. Does it result in a severe pain? And if the answer is yes, then I would start to think that it's likely discogenic pain. Right? And there have been studies which have associated scapular and high back pain with discogenic pain. But again, the scapular pain it can also happen in facet syndromes. Right? And this, right, they actually receive innervation from the posterior side, right, from the sinovertebral nerves, and laterally from the vertebral nerve, and anteriorly from the sympathetic trunks. So it's got a rather varied nerve supply. And the ingrowth of a large number of free nerve endings into diseased inner annulus and nucleus pulposus, they lead to discogenic pain. And they have also postulated that it's due to inflammatory mediators and high intradiscal pressure. Okay, and here is basically this graph here, right? It shows someone actually went in and intervened with co-ablation, that is basically a form of radiofrequency ablation, right? Particularly targeting the sinovertebral nerves. And at first week, the pain reduces, right? The VAS score drops to about half, and then subsequently it comes back. So again, now any form of neuropathic pain, we have to always, especially if you're doing an intervention, usually the expectation is very high, and I would try to bring the expectation down before I do anything. So this is an illustration of how this discogenic co-ablation can be done. So again, as surgeons, we tend to be more familiar and prefer to use the image intensifiers. It's not a very difficult procedure. You just need to identify the level which we want, right? And go in from a lateral trajectory into the intradiscal space and burn, right? But of course, the issue here is the trachea lies in the middle. That is quite easy for us to displace and avoid because it's a solid structure. But what lies beneath the trachea, which is the esophagus, that is something which we need to be really careful about, right? Because if we are not careful, we can just puncture through it and burn, and then after that, we
Oh,
think that we've done a good job. But I think all of us know having an esophageal fistula is probably the worst nightmare of a surgeon.
oh yes.
And of course, now there's also something called disco gel. Uh, it's basically alcohol with some viscous material. So what happens is the alcohol goes and you get chemoablation of the nerves, and the viscous gel it's purported to have to increase the height of the disc a little bit. The risk here, or the thing which I'm a bit concerned about with disco gel, is it needs to be a very well defined and contained disc. You cannot have any disc herniation as such. If there's any disc herniation, it's probably, there's a chance of it leaking, and the last thing we want is alcohol to leak out and get chemical ablation of the nerve roots. Another one would be ozone, but as we all know, ozone is not allowed in Malaysia. So now, myofascial pain is a paraspinal muscle pain which manifests as neck pain. It's mostly associated with mechanical factors such as postural dysfunction. That is very common in this day and age of handphones. Uh, Inadequate rest, overstretching, overshortening, or more generally overloading of muscles. And they often present with loss of strength, decrease in cervical range of motion, and altered muscle activation patterns. So remember, I was talking about trigger point. So I hope this image is at least legible.
Mm-hmm. It is.
It is all right. Good. So these dots are actually the common trigger points, but the one which I commonly encounter would be here in the upper trapezius, right? And somewhere in the rhomboids, as well as sometimes I do get middle trapezius as well. These are the most common sites where the trigger points are seen, in my practice at least. So now trigger point is very simple. I would prefer to actually use an insulin needle because it's short, it doesn't go too deep in, and it's just enough to hit the muscles enough, right? And usually, I think if we go for our massages, the masseuse or the therapist would tell us that, hey, this part, is hard, and they tend to
Oh,
concentrate
yes.
there. So exactly same thing. So now the only thing is this is wet needling
I see.
because they're actually finding our trigger points.
And this trigger point is actually the muscle that is in
It's in
spasm,
spasm. Yes, correct.
but there are many trigger points in me. It's like balls and balls. I thought they were cellulite.
No, they're actually muscle and spasm.
Oh, okay. Go on.
Okay.
Very interesting.
So basically you just look for the ball, right? And then you poke into the ball, and usually what you can use any form of local anesthetic you like. I think lignocaine is most commonly available. And any steroids, I like to use triamcinolone for this. If you do not have triamcinolone, dexamethasone also work. And just find the the ball, poke into the ball. Um, I commonly give about 2 cc's of total infiltration. But the trick here, right, is not just giving the infiltration and going off. You need to give the infiltration and give them the massage.
Oh my God. So you have a masseuse or you are the masseuse?
I'm the masseur now. I mean, you see, what happens is if you just give the injection there, it's just going to be there. You need to get it to spread around the muscle plane, right? The fascial plane. So sorry, you need to get it in between the fascicles and also when you massage a little bit, right? Even as you're massaging, you'll feel that the ball is missing. The ball now sort of disappears or melts or melts away. And once the ball melts away, then the patient will tell you, look, doctor, now I can start moving my shoulder well, before this I couldn't.
I see.
But of course, you need to tell them this is a temporary thing. You need to support it with exercise, physiotherapy, you know. And of course, again, going for physiotherapy just for that sometimes for someone who is busy or even someone who's not busy, especially you're coming to my center, right, a government center, you probably spend half a day for them to spend half an hour with you. So just asking them to do simple stretching exercises is actually quite adequate because the it's just to sort of maintain the spasm from happening or reduce the speed of the spasm from happening again. The spasm will happen again, there's no doubt about it. But by doing all these things, the spasm, the speed of it happening to that severity which warrants these injections and all is much more reduced. So what I normally will tell my patients is, look, I'm giving you this injection, not to, it's not a cure-all. It's just so that you are comfortable enough to initiate maintenance, which would be stretching and physiotherapy.
Okay.
Yep. Okay, so next is cervical radiculopathy. So basically, present as unilateral arm pain, numbness, tingling in the dermatomal distribution is typical what we learn in undergrad, right? In the hand, and there's weakness in the corresponding muscle groups. And as mentioned earlier, non-operative treatment is successful in about 75 to 90% of patients, unfortunately for me.
Hmm.
And surgical decompression is reserved for refractory cases or patients with progressive neurological deficits.
But when the nerves are involved, right, the pain is so bad.
Mm-hmm.
Usually, if it's non-operative treatment, how long will it take before they feel completely painless, like with
Okay,
pain?
all right. So now there are certain things which we need to look at. Now, number one is how severe is the pain, right? So
Yes.
if the severity isn't that much, then we can try with medical therapy just to control the pain. And usually the duration which I would tell, give the patient, and before I tell them, look, it's not successful, let's chop, 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 is about 3 months.
Oh, okay. 3 months is
Yeah.
a long time, okay?
Yep, exactly. Okay. The reason being is they've actually done studies and all, especially there's more experience with lumbar actually, whereby this herniations, right? If they were to regress, and they do regress, it occurs in about the first 3 months, and this regression does not it need not correspond with radiological regression. Means symptoms improve, but there's still this herniation,
I see. Okay.
right? The disc herniation still exists, but it's just that this herniation has retracted by maybe 2-3 millimeters, which is sufficient to not irritate the nerve root anymore.
Okay, I understand.
Yep.
Yeah.
Okay. So this is a typical diagram, to illustrate cervical radiculopathy.
Okay. I see it now.
Okay. Okay, I think we skipped this first. Oops. Hold on, yep, I think I got my slides slightly mixed up. It's okay. Okay, the interventions for cervical radiculopathy, I'll show you the illustration or the example later. So now there are certain pathological features or things to suggest pathological issues or red flags, right? So, first of all, it's trauma. So obviously, you can't just be relaxed and say that, look, it's just another degenerative process, right? If they have rheumatoid arthritis and they come and tell you that, look, I have this severe headache, neck pain, I have the stiffness of my neck, right? I have this easy, and it's associated with, this gait abnormalities. I'm walking clumsily, then I'm really worried about atlantoaxial subluxation, right? And atlantoaxial subluxation, if you allow it to progress, then it's the same thing as sort of a hangman's fracture kind of a thing, right? If there's constitutional symptoms, infective symptoms, upper motor neuron lesions, if they're less than 20 years old, and if there's concurrent chest pain, right? Because uh,
Huh.
neuropathic pain, especially if it involves the thoracic spine, it may mimic chest pain,
So I need to
right?
remember that because sometimes, patients complain of so much pain and it comes from the arm. The first thing you think about is the heart, but actually when we do something, we do an angio or CT angio and there's nothing, I must
Yep,
always remember it could be cervical or neck pain,
yep,
neck problem. Yeah.
yep, that's true. Right. Again, if they're more than 50, they're more prone to having uh, malignancies and pathological fractures, osteoporosis, right? This are basically signs, but I think what I tend to prefer to do is basically a Sperling sign, that would actually tell me if there's radiculopathy, right? And then after that, paraspinal tenderness or everything in between, it's a bit of a mix, like, if you ask me anything extra, Lemite sign, that would actually give you an idea if there's any cervical myelopathy. But usually it's history. That would actually give you about 80 to 90% of the diagnosis already.
Yeah.
And these signs are more just to sort of ancillary tests. If you ask me, if you allow me to commit myself.
Babinski sign, that sounds so familiar.
Sorry,
Babin,
Babinski's is a plantar reflex. Upgoing plantar, downgoing plantar, withdrawal reflex,
okay.
undergraduate.
Yes.
I,
No
I,
wonder.
I, I don't know whether Raymond, I don't think Raymond would have been your lecturer, right?
Who's Raymond? Oh, Raymond Ali?
Yeah.
Yeah, yeah, yeah. Raymond Ali was my lecturer.
Ah, okay.
Raymond Ali was my lecturer.
Izam Chong?
Izam Chong. Izam Chong, I think he he was a lecturer there, maybe even
Mhm.
professor, but um I don't think he taught me. Who taught me, and I remember very well, is actually the endocrinologist.
The late Khalid
But
Kadir.
yes, I enjoy his teaching very, very much.
Yep.
Yeah.
He sort of inspired me to be a lecturer now.
He, I don't think he inspired me to be a lecturer because I, but then, yeah, I enjoy his teaching very much. I never miss his teaching. He's an extremely good teacher.
Yep, that's true.
Okay.
Okay, now let's move on. Okay. So management, I wouldn't say anything fancy, all right? But as I mentioned earlier, the first thing with pain management is management of expectations.
Mm,
I think that falls true for most of our clinical practice. But the worst one, if you do not manage expectations well, would be pain management. So, first of all, obviously, we need to understand the expectations. So, if they tell you, doctor, my expectation is complete disappearance of the pain. That is going to be the most difficult thing for you to ever be able to achieve.
Really?
Because, yes, of course. Because you know what's going to happen? If let's say they've got a cervical radiculopathy, for example, right?
Yeah.
Okay, so we are able to identify and we give the appropriate block or the appropriate surgery and we relieve their cervical radiculopathy. But remember, this is wear and tear, so there would be some other wear and tear happening elsewhere. And then the next thing the patient tell, yeah, now that pain is gone, but now there's another pain there.
Okay.
You see?
Yes.
Because it's always, when you have multiple problems, the biggest problem manifests itself and disturbs you the most. And then when that biggest problem is solved, then the next biggest problem disturbs you
I
the
see.
most.
Oh my God, you got very sad patients. But
It's
I
not very sad patients, but if I do not manage the expectations well, I will be very sad because then they'll keep coming and telling me, doctor, what did you do?
yeah, well, you see it, but not so often. But yeah, you do see it.
Yep. So the other thing is to lower the expectations, right? So if they tell, look, I want the pain to disappear, what I would say that, okay, we will try, right? If it disappears, everyone is happy and it's a bonus. But now we are looking at more of reducing the pain. So if let's say now it's a visual analog score of 9, we hope to lower it down to about 2, 3, and then we try to support with other modalities,
Mm-hmm.
right? So it's multiple modalities, right? So that you can go on with an active life as possible. Compared to having a pain score of 9 and not being able to work, not even being able to move yourself to the washroom and whatever not. Now let's enable you to do that first, and then whether you can go for your taekwondo or karate, that we'll look at it later. And usually you spend time with them, explaining to them, they do understand and they say, okay, fine, I'll listen to you. But without doing that, if we go and intervene and promise them the sky and the moon, then the next thing is they're going to ask me, where's the sky and the moon? So it's always better to under promise. Okay, so after management of expectations, then I would go to exercise therapy. I use the term exercise therapy because there's physiotherapy and yes, it works very well, but getting the time commitment, the financial commitment for some people, to go for repeated physiotherapies. There's yoga and Pilates. Also, it does a lot of stretching, a lot of core muscle strengthening. That's what the physiotherapist does as well, right? And even if you can't do that, then at least spend time on yourself, do some stretching at home. There are plenty of stretching exercises which are available on YouTube, or on Google Pictures and whatever not, and all of them pretty much do the same thing. They teach you to stretch a particular set of group of muscles, so then you get relief of spasm or reduction of spasm, after which that you also get some increased strength. Because I always tell my patients, if with exercise therapy, what happens is, number one is stretching. Number two, I always give this analogy of our MRR2 or something which is always cracking. Then you always get the engineers going and putting scaffoldings. So these scaffoldings, they're small, but when you put multiple scaffoldings, which would be the muscle fibers, you get to relieve the pressure onto these joints a bit, and that would actually help in reducing pain. Um, After exercise therapy, the next step is medication. These are amitriptyline is a TCA antidepressant, but somehow it works quite well for neuropathic pain. Gabapentin, right? But gabapentin, one thing is you need to take 3 times a day, and it tends to cause a bit of additional sleepiness. Pregabalin is sort of an analog of gabapentin, but with fewer side effects, and you only need to take twice a day. And then your vitamin B, which would be your neurobion. And there's a local company which produces vitamin B with alpha lipoic acid. It's called BioNerve. Somehow it seems to work a little bit more than neurobion in my experience. Then of course comes my favorite thing, interventional procedures. So we can do blocks. That would be with local anesthetic mixed with a concoction or a cocktail with steroids. As I mentioned earlier, avoid particulate steroids. I prefer to just use dexamethasone. And then being a neurosurgeon, everything I'll give dexamethasone. Even if you have a brain tumor, I give a dexamethasone. Only thing is intravenous. All right. Thermal ablation. Okay. I know people use a lot of fancy terms, radio frequency ablation, pulse radio frequency, we do cool lift, whatever lift, but laser and all. But at the end of the day, it's thermal ablation, lah, right? You're modulating heat and either you're giving cold or you're giving hot, and that's it. You're trying to cause some form of a neurolysis, and that should last for about I would tell my patients anywhere between 6 months to 2 years. If you're lucky, extend to about 3 years. Blocks, I normally give them a duration of about 3 months to 6 months. Blocks, one thing you need to be careful about is when you give blocks, because the LA works first. So after about half an hour or so, they say that look, the pain improves, but it takes a couple of days for the effects of the steroids, the anti-inflammatory effects of the steroids to really take hold well. So then I would say that, after about a couple of hours, look, expect the pain to come back a bit, and then it will gradually improve. The nightmare would be when the patient comes and tells me immediately after the block, not even 2 minutes after the block, doctor, I feel extremely well. Then this nightmare for me.
Why, huh?
Because usually that extremely well will only last for about a month, sometimes even a week, and then they'll come and tell me that, doctor, that day I was extremely well. Now the pain has come back.
Okay, I
Then
had that before. So I can relate to all this pain because I had this pain before for my lumbar problem. And
I see, I see.
yeah. Okay,
All right. And then, of course, being a surgeon, I cannot avoid talking about surgery, which would be a fusion as well as endoscopic decompression. Okay, this is nothing fancy. It's just to show how the radio frequency ablator looks like. So this would be the generator, and this would be the needle. Okay, and you see, I do not have any preference to any particular brand. I just use whatever because all of them seem to work equally fine to me. Okay, a bit of technicalities, nothing important here. It's just that when they mention thermal RF, you're looking at about 70 to 90 degrees. Pulse RF is less than 42 degrees. So with the reduced heat, the efficacy which has been purported is shorter compared to thermal RF. But here, 48 months, difficult to find, lah, especially in our local population. I would say 2 years, 2.5 years max before they start complaining again. Okay, yep, surgery decompression, right? The why I wanted to show this is yep, okay. So if the nerve root is impinged, right, and you just need to decompress the bone and the nerve root can be released. So even if there is a disc, let's say there's a small disc protruding here and compressing onto the nerve root, you needn't actually go from anterior and take out the whole disc and do an anterior cervical discectomy and fusion. You can actually go posteriorly and drill off a bit of the bone, right, which is part of the lamina and facet, And that would actually give space, that would allow for decompression of the nerve root, and symptoms will improve. And this is starting to uh, to become more and more popular these days because everyone wants to go and sing their karaoke, right?
Oh, I had the patient also who had this, he was so disturbed by the pain in his heart when he sang karaoke.
Mhm. Okay.
Yeah, yeah, yeah. He had chest pain when he had to strain to sing all those high notes.
Okay, okay, all right,
Funny,
all
yeah, I
right.
never, okay. So
Yeah,
these were
but here,
people who sing karaoke?
no, no, no. What I meant is if you're going to do an anterior approach to remove the disc, anterior cervical discectomy and fusion, you actually need to retract the recurrent laryngeal nerve. So when you retract the recurrent laryngeal nerve, there's a possibility of injury, and then your voice becomes hoarse, and then you can't go and sing your karaoke.
I see.
Unless you want to sing it like me, like like it's exactly like a toad. So these days, people, some of them they prefer to just go to the back, release the bone a bit, and then give space for the nerve root. And when I talk to patients, I just tell them, we give space for the nerve root to breathe, which in a way is true as well, because part of the reason why there is pain is because these vessels which run on the root, they become ischemic, and that results in the pain. So once you decompress, there's good blood flow back, there's good vasculature, the pain improves. Okay, I remember I was talking about cervical radiculopathy, and you asked me that, okay, now the pain can be very severe,
Yes.
right?
I think
So,
any nerve pain can be very severe because when I had
yep.
my lumbar spine problem, right?
Mm-hmm.
Well, I can stand pain, but that pain I couldn't stand at all. I really couldn't. I couldn't work.
Uh-huh. So here, what we can do is we can actually just block the nerve root. Hence, it's also called diagnostic blocks. So then we'll also be able to identify if, let's say, there are multiple disc protrusions, and there might only just be one particular nerve root which is actually causing the pain. So you can choose to block one by one if you want to. And again, remember I said these blocks, they should last about 3 to 6 months. And I did mention that, this also, they tend to have this whatever minimal retraction happening in about 3 months. So the timing is just about nice for the effect of the block to disappear and the minimal retraction of this protruded disc to happen. And then, yep, if all fails, right, we can just do a cervical epidural block. Basically, we just wash the epidural space with steroids as well as local anesthetic. So most of the pain just disappears like that, but it doesn't have much diagnostic value. Okay, this is just trying to share a few of my cases. So this is for radiculopathy. It's basically a 27-year-old male. He's a lorry driver, and what happened was while he was working, the the lorry was in a quarry or something like that, and just turned turtle.
Oh my God.
So after which he developed the sudden onset of right-sided neck pain, which shoots to the thumb on the right side, lah. And it was there for about 6 months. It's very severe pain, like what you said.
Yeah.
He has been given gabapentin, pregabalin, amitriptyline. Some people even gave him Ultracet and all. Pain never improved. And then someone actually referred to me for nucleoplasty, right? So that's basically a coablation. They thought it's the disc which is the pain generator. And then after, examining and all those things, then, but then he didn't have any muscle weakness, but it tells very typical radiculopathy. And the way how he controls the pain himself is very funny. He had one of these the grip strengthening stuff. So he was just constantly doing that because that gave him some relief to the pain. So this was his X-ray. So now there's a bit of loss of lordosis. Normally this lordosis, the C shape or reverse C. But here there's sort of a simple C shape, and then you can also see the this height anteriorly. This is 2, 3, 4, 5. So between 5, 6 is reduced to sort of a wedge shape. And then we proceeded with MRI. So now you can see the loss of lordosis quite easily. And then now the wedge shape here is 2, 3, 4, 5. So 4, 5, right, and 5, 6. And this is straightening and kinking of the cervical spinal cord, right? The cervical portion of the spinal cord. And there is reduced CSF space on T2. So this is axial view. You can actually see on the right side, there's increased compression of the spinal cord, and there's narrowing of the exit foramina here. So for Facebook purposes, no intraoperative photos or videos, unfortunately. But basically, we went in and did a 2-level ACDF for him. So now you can actually see, the C shape, right, from one which is being bent forward. Now it's a bit more bending backwards. So there is some restoration of the normal lordosis. Of course, after this, pain improved, radiculopathy disappeared. This was about 2 years ago. And then I think about 4 months ago, he came back. Now he was complaining of neck pain again. But this time it was facet pain. So
Was it due
fortunately,
to the same thing? Was it due to the same surgery, the same accident, or it's not related at all?
it may not be. It's very difficult. That's why I remember I told you the worst problem manifests itself.
Oh, yes,
And
that's right.
yeah, so maybe whatever cervical pain he had didn't really manifest itself at that point in time. It's just that after some time, physiotherapy and going back to work. I mean, he's back to work. He's back as a lorry driver. Uh, but after some time, only these things will start to crop up again. Maybe he was in euphoric stage. That severe pain had disappeared. That he didn't take notice of this other pain, which is the facet pain. So anyway, he came, intervened, and now he's much better. Okay, red flags, something which we need to be really worried about. I mean, careful with. So this is a 56-year-old lady. She basically presented to me with neck pain. Otherwise, activities of daily living she was independent. She was actually working as a manual laborer, right? A lot of manual work, hard work, no issues at work. Okay, and then upon examination, you noted she's got some problem with her grip. Opposition was a problem, Tinel sign was positive. So thought she's got carpal tunnel syndrome. However, one of her relatives actually came and, said, but then, she keeps falling from the motorcycle because she drives a motorcycle to work. So, and then, on questioning her, she was just telling that, look, I'm perfectly fine. I don't have any other issues. And then finally she said that, look, I'm actually having some recurrent episodes of clumsiness where I almost fall. I do not fall, but I'm almost falling when I walk and I try to do things fast. So then we went ahead and did an X-ray for her first, right? So a lot of osteophytes. So these osteophytes, remember I said, they are sort of an indication there's some form of an instability happening there as well, right? There's also reduced joint space here. So we went ahead and did the flexion extension. I'm a fan of flexion extension because that may not give me additional business by showing there's instability. All right. So anyways, spine also looks pretty stable, right, on flexion extension. But then when we went ahead and did MRI, because she's got this myelopathic symptoms. For me, this clumsiness is myelopathy. Power on examination was 5.5 for her. But she was having very subtle symptoms, which was that clumsiness. And lo and behold, she's got multiple levels of this herniation. Right, there's pretty bad stenosis here. So we went ahead and did ACDF again. Symptoms improved. And then now she went for her carpal tunnel release and back to work. Okay, I'm sorry. I tried to find this is actually someone who has got basilar invagination. So basically the C1, sorry, the C2, the dents, it actually goes up and pokes onto your medulla. So this particular boy, he presented to us with severe headache. And upon investigations, we found that, he's got basilar invagination, and we went and did. This is just to show that, there's technology now which makes surgery much more safer. So basically, this thing just guides our screw in. Of course, it guides our screw in, but if screw goes elsewhere, we are the one who's screwed. All right.
Okay, we need to finish off. Okay, you
Yep,
finished
I'm done.
off. Okay, great. Because we have a question from Dr. Ng. How many months for reticulopathy symptoms to improve? I think just now we asked that. With or without surgery? I think without surgery, you said about 3 months, right?
Yep.
Okay, so that about that. And Dr. Kasim from Dokwiti asked, neck pain is a hot topic. Have patients come with neck pain but can't exactly explain? I mean, you don't come to a diagnosis. True.
Yes. Yeah. I think with any disease, there are times where you just do not know what, and then you tend to tell them, okay, hold on, we'll do some investigations, and then you send them off, see them in 2 weeks or a month, and then you start asking around your colleagues, hey, I have this funny case, right? But of course, if you just want to manage the pain, managing the pain is not very difficult. Actually, treating the pain isn't difficult, but to come with a good and accurate diagnosis so that you can continuously monitor and do some precision medicine, right? That's what Beacon is doing now, precision medicine. So precision medicine, that it would be the challenge in the small cohort of patients. And then of course you also have those people, it happens in the US very often. They've got secondary gains to it. That is another issue.
Yeah, it's not uncommon not to find anything. And it's not that the patient is lying about the pain. They do feel the pain. But sometimes it is, maybe you have to rule out anxiety, depression. Sometimes it's a call for help for something.
Yeah.
Yeah.
Okay. Sorry. Since we are at that, right? Actually, not to put it psychiatric, psychological issues, right?
Yes.
They tend to have a magnification effect on pain. So
Because
if we do
you're
not address
anxious.
both,
Yeah.
yeah. So if we do not address both components, then again we are left with a unhappy patient, which results us going into depression now.
Oh, you get pain and depression quite easily from your patient. Thank God I don't get that. Okay, Dr. Prof. Sushil Kumar asked, would you think that a neck pain, whatever the cause, may be a cause of optic neuropathy? Optic is eye, right?
Optic neuropathy. I'm not too sure. I mean, what is running through the doctor's mind?
Yeah, I also cannot because optic
Yep.
is no. I don't think. I think the cranial nerves don't come so near the neck. Optic nerve is actually one of the cranial nerve. Is it the third cranial nerve? Can someone?
No, it's the second, the second.
Okay. Okay.
Okay, Raymond is going to start
Oh,
rolling.
sorry. I'm so sorry. You're the new neurosurgeon here. I forgot. So no, I don't think it has got anything to do with optic neuropathy.
Optic
Okay, but
neuropathy per se, I mean, this one I have to just hazard a guess, a calculated guess. I don't think so.
yeah.
All right. If occipital neuralgia, someone put there, occipital neuralgia, I think he meant that. That is yes. I would say it's yes. Then it's called something called the third occipital nerve, blah blah blah. Then you actually need to do a diagnostic block of the third occipital nerve, and pain resolves. We know that's that.
Does this neck pain can this what trigeminal neuralgia be part of a neck pain?
Okay, trigeminal neuralgia. Trigeminal neuralgia. Okay, trigeminal neuralgia by definition would be pain over distribution of your trigeminal nerve, correct?
Yes, that's right.
All right. So now trigeminal neuralgia, most commonly, if you think
Is it the
along the lines of the surgeon, is because of a vessel compressing onto the trigeminal nerve. If you're thinking along lines of a physician, then it is some form of demyelination occurring, right, in the brainstem. And from the neck, actually, your trigeminal nerves, the nuclei, right, they actually go all the way down to around your C1, C0, C1
I see.
in the brainstem,
Mm-hmm.
all right? And you also have your C1 nerve root coming out, your C2 nerve roots coming out. So there is sort of a plexus or communication occurring there as well. So now when you get a short circuit in your C1, C2, yes, it can actually affect
So it
your
can be part
trigeminal
of the,
nuclei.
yeah.
Yep, and which results in facial pain. This is something which I I mean I enjoy doing because after you give a block, they say, doctor, it's fine, lah.
Yeah, because
And
the pain is
but
very,
before that, they normally ask, my pain is in my face. Why are you poking at the back?
I see.
Right.
It's a very severe pain, you know.
Yep. But that would be more towards the atypical facial pain syndrome rather than a trigeminal neuralgia per se.
Okay. So we have another question from Dr. Hui asks, I've met many patients with missed fracture of the cervical spine post-fall. What can we do about all fracture if patient presents with pain?
All fracture, it depends where this fractures, right? I mean, whether is it united or not, and most of the time they would have had some form of a union already. So now, if there's a disruption in the anatomy, you've got a change in height and whatever, then this predisposes to uh, cervical spondylosis, and then we need to see where the pain generators are, right? But if you ask me, would I go and do surgery? Would I go and do a fusion and all for these patients? Most of the time, the answer is no. I just need to address the pain generators, because if I go and do surgery and the pain generator is not addressed, that is probably going to be my worst nightmare. The patient is going to come back and over and over and over again.
True. Okay. So I think we have gone past 10. And there's no more questions. Okay, we will end here. Thank you very much, Balani. See you one day again.
Yep, sure. Thank you. Thanks a lot, Betty.
During one of the dinners, maybe, if we could. Raymond always, are you going for the next one? Okay, wait, thank you. Wait, let me just end the recording.